Thanks to Dr. Islam for this kind invitation, and Amar as well. I should congratulate the organizing team. I can see more than 1,000 participants. Amazing on a Friday afternoon. So well done. And it was amazing listening to Professor Hania, who is a real expert in the field, and she has given us a very clear outline on what to expect. So some of my slides may overlap on parts that she had covered, so I'll not focus too much on the part she has already covered. So I'm giving an overview of the topic, focusing on cesarean section deliveries and whether we should consider probiotic supplementation in this group. So we already discussed that this is the most researched topic in recent years, and as she said, obviously COVID-19 is the most researched topic in this year. 2020 is different for every possible reason, unfortunately. So we have the host and the microbiota together forming a complex ecological system. And as she rightly said, the dysbiosis, where there is an imbalance between the microbiota-host interaction, can have health consequences, both in the immediate period and in the future. So birth by cesarean delivery is a risk factor for altering this gut microbiota pattern, and it's a critical first few days to weeks of life. So all of us are familiar with the epigenetics, pre-programming and everything like that, and the immune tolerance, the gut-brain axis, it's a crucial period. So that's why the first few days makes a big difference, and I'll discuss that in detail as well. So this could possibly be improved by regulation of the factors that affect the gut microbiota, and probiotics obviously is one of the factors that could impact this, and we will be discussing that. So this we already discussed, and it was interesting to see that the number has become from 10 times to 1.3:1. So I stand corrected here. And obviously we have a huge bulk of microbial cells on our skin, in the mouth, and obviously in the vagina as well, and in the intestinal tract, which is the biggest number. And as Dr. Hania said, we have nearly 100 to 200 times of genetic material in our gut microbiome. And all of you would be very interested in following that some of the cultural changes we see, some of the memories we have come from actually the memory in our genes in the gut microbiome, not necessarily in our own genes. So interesting. In terms of how the microbiota can impact, we have the vertical transmission of maternal microbes to the offspring. And this is a critical factor in the development of the host immunity in terms of immune tolerance, for example, the good versus the bad bacteria, the pathogens versus the supportive organisms. And it also affects the metabolic development. So this metabolic development is basically the same hypothesis as we have for pre-programming in terms of growth restriction and future health. So pre-programming happens with epigenetic basis, and the chemicals produced by these bacteria, the short chain fatty acids especially, have a big role, and the neurotransmitters, the gut paracrine system as well. So wiring of the gut-brain axis, we will discuss what we mean by that. And we have the early exposures that impact the intestinal microbiota. And as Dr. Hani illustrated, and we'll see later, multiple diseases are associated. So we have the gut microbiota. We have various factors which influence the gut microbiota, starting from even before conception, before delivery and after delivery situations. We'll be discussing those. Then we have the human diet, which provides a substrate for these microbiota. So changes in the diet may lead to different modifications in the microbiome, and that's one of the reasons why we feel slightly different when we travel to different time zones where our food habits change. The same applies to children as well when they change carers and so on. So this modified gut microbiota plus the nutritional change may lead to metabolic problems. So we have inflammatory bowel disease, immune diseases like asthma and diabetes possibly, and the metabolic diseases. And we have the brain-related conditions, the psychological diseases. Autism is also linked these days, and intelligence is also linked, and memory, I told you about the impact of these on our memory response through generations. So the first 1,000 days, everyone has been stressing on this. It's a very important period, starting from conception until the end of the child's second year. So obviously, a lot of development changes in the womb, and the brain development is the fastest in the first 18 months to 2 years of age. So the first 1,000 days is a very critical period. And when the mother is pregnant, obviously, there may be environmental disturbances that may have a profound and enduring structural and functional consequences. So this may be in the form of infection that happens in the mother, stress during pregnancy, drugs and alcohol exposure, prematurity, obviously, both from the reason why the prematurity happened in the first place, as well as the dysbiosis that is associated with care in the NICU, our procedures done, the antibiotic usage, possibly birth by cesarean as well here. And in term babies, we have the mode of delivery. So we will be discussing more about that. Feeding method, whether it is breastfeeding or formula feeding, it makes a huge difference. And if you're not exclusively breastfeeding, even partially formula feeding may affect the gut microbiome significantly. And of course, the use of antibiotics, which most of us are now going for minimizing the use of antibiotics. Even if we use for suspicion, we try to stop it at the earliest, and we try to rationalize avoiding the use of broad spectrum antibiotics, which are going to have a wider effect on our microbiome. So how does the microbiota impact on brain development? So the post-birth neonatal period is a critical window, obviously, and exposure to bacteria during birth is a critical juncture in the establishment of stable gut microbiota. And these gut microbiota can impact on the brain physiology in the form of impact on synaptogenesis, which is a formation of the dendritic connections and the synapses, which is the wiring is continuous process in the first few months, and this process is affected. Then we have the supporting structure of the brain, the microglia, which develop and mature, and part of it may be the development of the myelination as well, and regulation of neurotransmitters and neurotrophic factors such as the brain-derived neurotrophic factors. So all these can be impacted by the changes in our gut microbiota, and it can have impact on our behavior as well as subsequent functional development. That's why it may impact on even intelligence. So there is overwhelming evidence that the microbiota play a crucial role in the postnatal development and maturation of the nervous system. However, we are still not clear how the disturbance in the microbiota development can lead to abnormal brain development, cognitive behavioral changes, allergy and autoimmunity, and metabolic disorders. So there is multiple links, exact mechanisms. We have plausible mechanisms, and hopefully we will be showing the exact mechanism soon. So this is one way how it can affect the long-term outcome. So the chemicals that are produced locally by these gut microbiota, they metabolize the different, even the human milk oligosaccharides, which are currently being studied, are broken down by bacteria like the bifidobacterium, and multiple short chain fatty acids, which have different functions, are produced locally. They have local effect as well as the neuroendocrine mechanisms. They have effect on inhibiting pathogens as well. And there is effect on central nervous system excitability. So interestingly, this could be the mechanism how colic can be inhibited, because the excitability of the central nervous system, how the baby self-regulates, how the baby soothes. This is related to an irritable baby. If you're not having a good gut microbiota, probably the baby's ability to self-regulate is less. And there is also impact through the vagus nerve. Vagus nerve is very important because the gut innervation is through the vagus nerve. And as we know, the parasympathetic supply to the heart, and as well as the parasympathetic nervous system effect on our blood pressure and breathing control is through the vagus nerve. And so because of this innervation and the exposure at the gut level, there is a programming of the effect of the vagus nerve, and this could be one of the reasons why we have a future impact on hypertension and heart disease and so on. And we have the chemicals released locally, which are neurotransmitters as well, and they may reach through the blood-brain barrier to the brain as well. So we have serotonin, GABA, glutamate, etc., which may affect the brain. And of course, we have the modification of the immune system, the pro versus anti-inflammatory effect. So where there is a good regulation of the gut bacteria, where it is in balance, we have Th1 predominance, which keeps the allergy and autoimmunity reduced, while Th2 predominance can be negative. And even in the local milieu of the gut, whether there is a tolerant in the premature baby with dysbiosis, we have a high risk of necrotizing enterocolitis because there is a disruptive milieu and it's a bit chaotic. So you may have damage to the mucosa, submucosal gas, which is anematosis, and so on. And the toll-like receptors and chemicals like the cytokines, the platelet activating factors have a big link to this mechanism. So this interesting slide shows us how we tolerate. So the immune tolerance We have the old friends, which are the bacteria which have been associated with our gut for generations together. And this is what the mother does. She transfers these bacteria to the baby at the time of delivery. Probably we are even exposed within the womb. So even though studies have shown that the bacterial genetic material is found in the placenta and in the amniotic sac, we cannot culture the live bacteria. Either it is the bacteria coming from the mother's oral cavity when she brushes her teeth, there is a bacteremia and this goes through. And so even in the womb, baby is exposed. So these are the old friends, generations through adaptation is there. The dendritic cell is exposed to these during the process of maturation. And these mature dendritic cells have an awareness of self. So this increased awareness of self is very important to reduce autoimmunity. And when we get re-exposed to the same bacteria after birth, the T regulatory cells are activated towards the Th1 response. So we have more tolerance related response. So we have a reduced inflammatory response to these good bacteria. And at the same time, if you are growing up in a, I mean, this is similar to the hygiene hypothesis, where if you're growing up in a farm or a field where you have a lot of exposure to community bacteria, you're more likely to show a Th1 response or less of allergy. So the composition of the intestinal microbiota is determined by several endogenous mucosal and luminous factors in the GI tract, and this illustrates all the influences that are there. So we have the diet, breastfeeding, and when you start weaning foods, what kind of food you consume, antibiotic exposure both in the mother and in the baby, environmental bacteria. So the more bacteria we have, and Dr. Hania mentioned beautifully about the effect of the current crisis, our overuse of disinfectants probably, and what it will have as an effect on the current generation of babies. Use of pro and prebiotics, the mode of delivery, and these factors are in the host. So we have the gut structure. So if it's a premature baby, the gut structure is immature. Genetic factors and epigenetics we discussed, passing on through memory from generations before exposure. For example, vegetarian populations may have a different gut microbiota. The parents who are obese may have a different set of gut microbiota, and these may be transferred to the baby as well. And how the baby reacts, how the baby's genetic system reacts, this is epigenetics part of it. And we have the gut immunity, how it is organized, how the baby is mature at birth, and so on. So this shows us how the microflora evolves with life, and this is a constantly changing picture. I mean, as Dr. Hania was illustrating, every year we get more information. Even the count of cells has become perfected now. And this information, this is an overview basically, and we can see that the bifidobacterium peaks very fast and then it stabilizes, and we have bacteroids which starts going up, and there are differences in species. So we have the bifidobacterium dropping after the adulthood, bacteroids stay at a high level, and we have some organisms like Clostridia and so on, which may be higher in the Caesarean group. So this also shows us the same slide that Dr. Hania illustrated. So this is the same group who studied vaginal seeding, and very beautifully illustrated. So it's just easy to compare that in a mother's vagina, the color coding is enough for you to know. So just look at the baby born vaginally, how the growth of the gut microbiota pattern is, and this is the mother's vaginal flora. Exact same matching, even though the extent, the number of bacteria may be different. It obviously becomes more with the age of the baby growing. And this is the mother's skin. And obviously after the cesarean delivery, you can see how closely it mimics the mother's skin. And in terms of a premature baby, when the baby comes to the NICU, we have, in addition to the mother's skin, we have colonization with the environmental bacteria. The coagulase negative staphylococcus colonizes the skin, and pathogens like the ESBL may colonize the gut. So we have a high risk of sepsis from these bacteria once a premature baby is at risk. So this is a beautiful slide, and this is one of the principles for why vaginal seeding was considered, and the group tested it. This is again to illustrate the effect of feeding. In breastfeeding babies, there is an abrupt rise in bifidobacteria. The ability of the bifidobacteria to digest the human milk oligosaccharides is a big plus, and that allows them to stand fast against the other pathogens. And that's why breastfeeding is beautiful. Nothing beats breastfeeding, and so our focus should be on breastfeeding, and as we will discuss now about reducing cesareans as well, hopefully. So supplementing probiotics comes next. We try to prevent the situation happening first, and that's where breastfeeding and reducing cesareans would have. So this talk should be reaching obstetricians as well, and I'm sure Dr. Islam would arrange a talk for the obstetricians on the same topic. So in terms of bottle-fed babies, you see that the pattern is different, and the bifidobacteria peak is reached later, and we do have E. coli predominating in the initial stages, which is not a good situation. So coming to the topic of interest, so cesarean section is basically babies born by surgery, and this was described as early as 750 BC. We know that there is a controversy about Julius Caesar being born by cesarean. So the fact is that he was not really born by cesarean, but one of the Caesars were born, and mainly used to safely deliver the baby without risking the mother's health, where safe vaginal delivery may not be feasible. But now it's going more and more as a cultural habit, and obviously, the affordability in the community is leading to more issues. An increasing rate is noted in almost all countries. So we have studies looking at cesarean rates right from the 1960s onwards. And in 2004 to 5, the rates were around 15% was considered reasonable, and the WHO said rate of 10 to 15% is acceptable. Developing countries like in Africa, probably because of the cost factor and the availability of healthcare resources, it was 5 to 7%. In the Middle East as well, we have studies in the 2004-5, which were talking of 10 to 15% being high. And the approach to cesarean sections is changing. And in UK, for example, the past 8 years or so, even the NHS is allowing maternal choice as an indication for cesarean delivery. This is because of the risk of litigation from birth asphyxia, if at all there is a problematic labor process. In the UK, the rates are still around 25 to 30%, and in the US, 30 to 35% is now considered reasonable. So you can see in 15 years' time, the rate has almost doubled to a reasonable level. However, in many private centers in UAE, we see the rates of 35 to 50%, sometimes hitting 60%, and this is described in Brazil and China as well. So we are going to a situation where one cesarean is done for various reasons, and then you get repeated pregnancies having elective cesarean subsequently. So it's a vicious cycle. And obviously the convenience comes from predictability part. Suppose you are in a clinic setup and you don't have a regular obstetric service in the hospital, the obstetrician would rather deliver them rather than risk having to come from home out of hours with the risk of asphyxia and not monitoring adequately. So this convenience part and the predictability part, okay, it makes it safe, but at the same time, you are exposing the mother and baby to multiple factors. And the outcome effects of cesarean on the mother, the maternal risk is minimized by advances in anesthesia and aseptic procedures. And this is where antibiotics come in. So most of these mothers receive antibiotic as well. Just before the cesarean, 30 minutes before is the recommendation, but sometimes they give it 1 hour before, and it may actually reach the baby, and it can affect the gut colonization. The pain is more difficult than the vaginal deliveries, and this may lead to initial lactogenesis problems. They are more likely to use some formula feed. So even if it is for 1 or 2 days, the baby is not getting the breastfeeding and the colostrum alone in the critical period. I told you about the critical time window. And prolonged healing time, there is a risk of bleeding, fluid embolism, and infective complications. On the baby, we may have short and long-term effects. The short-term effects are maternal pain and discomfort, which affect the bonding and breastfeeding comfort. Exclusive breastfeeding rate is shown to be lower in babies born by cesarean delivery. And the gut colonization pattern we already discussed. And long-term outcomes are obviously multifactorial. But there is no doubt, Dr. Hania showed us the forest plot, and this is a slide form, a table form of the same condition. So we have all cesarean deliveries and repeat cesarean. Repeat cesareans are obviously before the onset of labor. So there is a difference in how much impact is there, whether the labor process has started, the cytokine response, the chemical changes related to labor has started. That is an emergency cesarean. And if it's a repeat cesarean, it's mostly elective. So very rarely that we get an emergency repeat cesarean. And so here in asthma, female is also a risk because of additional factors. And we can see that all of these are significantly increased in the cesarean population. So we have allergic rhinitis, asthma, celiac disease, type 1 diabetes mellitus. So all of you may be familiar with the TEDdy study, which looked at the gut bacteria and diabetes mellitus type 1. And they have also clearly shown that the TEDdy 2 study showed that we have a change in the short chain fatty acid production rate, and that is actually the reason why the risk is more. So the metabolites produced by our good bacteria are responsible for these effects as well. So we have the difference of bacterial baptism of vaginal birth. So when the mother is delivering the baby vaginally, her bacteria are given to the baby, that's a baptism, and all the memory response, epigenetic response goes with it. This is bypassed by the cesarean delivery, and this abnormal establishment of the early life microbiome could mediate later life adverse outcomes observed in the cesarean. So we have these conditions we discussed. In addition, we have ADHD, autism, and OCD as well. So the neurobehavioral effects, which I mentioned about the dysbiosis, how it impacts, that's where this condition is associated. And Dr. Harnia clearly said that these are only associations. Obviously, these are plausible associations, so we can explain how it works to a reasonable extent. So we have to take it seriously, and obviously that's where our treatment concerns come in. So we have a definite proof that the gut microbiota are different. We saw that in the slide earlier in the study done. And we have lower total diversity of the microbiota. We have lower diversity of bacteroid species during the first 2 years. The Firmicute species is more predominant in this group. And we have more of E. coli, Clostridium difficile, and Tropinobacterium. And vaginal seeding was published by Dominguez Bello et al. And she is a biochemist actually who is very interested in this topic, and she has done multiple studies. And in the first pilot study, they demonstrated that vaginal seeding could successfully colonize C-section infants with vaginal bacteria. So basically, they swab the mother's vagina with a saline-soaked gauze, and they treat the baby's mouth as well as the skin within the first hour of life with this swab. And only 4 babies were studied for 30 days, and they clearly showed that the bacterial seeding could be influenced by this process. So, however, this influences the bacterial seeding. We don't know about the long-term outcome, and there was some concern about risk of infection, especially group B streptococcus, or if the mother had vaginosis, for example. So vaginal seeding is only one component. Cesarean section can affect by different ways. So we have the indication for cesarean delivery, the stress related to the condition like cord prolapse or abruption, for example. We have the elective versus emergency, where the hormonal and cytokine changes with labor can impact. We have the antibiotic administration in the mother, and differences in breastfeeding behaviors, which we discussed due to the pain related to the cesarean and the anesthesia effects. The maternal obesity may be one of the contributing factors for why labor does not progress and why she may need a cesarean, and of course the gestational age as well. All these can influence, and this slide illustrates how maternal inflammation or prenatal stress, cesarean section lead to dysbiosis, and the exposure of the bacteria at this level leads to cytokine release from the leaky gut, and this can cause a greater blood-brain barrier permeability, neuroinflammation, and so abnormal neuronal development. So this is the gut-brain axis wiring related effect, and we also have effect on the vagus nerve. All these combined together cause the cognitive and behavioral effects, and possibly through the effect on the vagus as well as the immune dysregulation. So for example, clearing of atherosclerotic elements from the vessels can be affected, and the metabolic changes, the type 1 diabetes risk we discussed, and the effect of blood pressure on the vagal stimulation. So we have, and the Th1, Th2 regulation causes allergy, autoimmunity effect. So this slide illustrates how multiple aspects are impacted. So the blood-brain barrier is essential for protecting neonates, and the abnormal gut microbiome development can actually lead to altered blood-brain barrier permeability, and this could explain why we have this issue. So is there any evidence that in the critical period probiotic supplement would help? So there is a critical time window within which certain deficits of the gut microbiota axis can be amenable to microbial intervention. And germ-free mice experiments have shown the enhanced hypothalamic pituitary adrenal axis response was partly corrected by probiotics at an early stage. Bacterial colonization at the post-weaning stage also normalized alteration in anxiety-like behavior and blood-brain barrier permeability. The dietary short-chain fatty acids as well as the microbiota-derived metabolites or the bacteria that produce them can reverse alteration in the above as well. And these are time dependent, and these defects become permanent or irreversible if your action is delayed. That's why if we think probiotic supplementation will help, we may have to do it early in the stage. And data suggests that the gut microbiota is capable of modifying the brain development, and the critical influence is there. We have seen benefit. Dr. Hania projected the slides of benefit in reducing eczema mainly, and so modification over a period of time. So what are the options we have? The composition can be influenced by vaginal seeding, for example, and probiotic supplementation in the critical period. And this shows us the multiple interventions we can use. So vaginal seeding, breastfeeding and donor breast milk, probiotics, prebiotics and symbiotics combined together. The polyunsaturated fatty acid supplementation in infant formula is one option, and the environment, I mean more green environment, for example, not being confined to closed spaces where we use disinfectants. And obviously reducing cesarean delivery is one of the important effects as well. And if they are born by cesarean, you may consider one of these interventions or more of them, because we don't know which factor will be more important and we can try more. This I will skip because we already know what Dr. Hania illustrated and we are running out of time. So we have components also. I mean, we have live bacteria and we have components from them. And even the components which are extracted could have effect based on the chemicals that are produced by the probiotics. And studies have shown that maternal supplementation with Lactobacillus GG showed increase in this species as well as Bifidobacterium longum, because it makes the environment more suitable for Bifidobacterium. Probiotics in preterm babies, she illustrated clearly, has been shown to reduce NEC, and she also showed us which strains to target from the current ESPGAN guidelines. And use of prebiotics and symbiotics improves gut colonization pattern. Breastfeeding has a significant impact. So this is the key factor that we should target from antenatal period, counsel the mother to breastfeed. And this will have an impact on reducing this, even if they are born by cesarean to some extent. Coming to the cesarean delivery babies, there was a study in Thailand and Indonesia by Titi Uniati, and this was published in 2016. And the babies were supplemented with Bifidobacterium lactis, BB12 species, in the first 2 weeks, and continued till 2 months of age. This was done in both breastfeeding and formula-fed babies, and they didn't separate the babies born by normal delivery or cesarean. So they showed an increase in the stool Bifidobacterium lactis in the babies born by cesarean. The effect is more in the babies born by cesarean because in the breastfeeding babies and those born vaginally, there is already a high Bifidobacterium load, and the different species of Bifidobacterium from the mother may inhibit this Bifidobacterium lactis colonizing more. But when there is a background deficiency of Bifidobacterium, the ones that we are supplementing does take hold. So that is important for us to remember when we think of supplementing babies born by cesarean from the early stages. So we know that the bacteria does take hold, and this was shown to be persistent till 2 months. Follow-up probably will be done on this group. So probiotics like Bifidobacterium lactis could be considered to improve the gut microbiota pattern. And again, this shows that the pattern can be improved, but whether the long-term outcome will change, only time will tell. And choice of probiotic, we should, again, Dr. Hania dealt in detail, we should be having something with good tolerance. Quality control in production, safety and efficacy is important. How it is formulated, and post-manufacture quality control, whether they are monitoring it post-manufacture. So we should go for good brands which are produced with a good quality control and not off-the-shelf products. And lyophilized formulations are more likely to ensure dose accuracy and stability of the viable probiotic strain. And they may also retain some of the chemicals, as I mentioned, the short-chain fatty acids and so on, in the environment of the probiotics, which might be useful. So the BB12 is currently available in the lyophilized form as a Linux baby, and the sachet contains 1.2 times 10 to the power of 9 bacteria. The probiotic should not be given where there is a risk of immunocompromise, and the clinical stability and safety should obviously play a significant role in the choice of the product. So to conclude, I have not given you a clear answer because the answer is not known, but there is a plausible explanation for why supplementing at an early stage. So if you are thinking of supplementing, we should discuss this with the families. This is very important, where we don't have a clear-cut strong evidence for the future, but there could be a potential effect. So she also showed the BB12 in the last 2020 study that it has an effect on infantile colic as well. So we have two reasons where we could discuss with the families born by cesarean delivery, or where the parents are unable to breastfeed or supplementing with formula feed for any reason. In the premature babies, of course, our choice should depend on the ESPGAN guidelines for NEC control. And routine usage, it would be difficult to recommend strongly at the moment. So the choice will be depending on the parents agreeing to it, the cost factors involved, because insurance may not cover these products. So we have to be clear in the discussion with the family that you have to supplement at least for the first 2 to 3 months of age, because that's a critical period, and you may have to keep it going. It could have benefit in the long run in their long-term health, as well as possibly in the short term in the form of colic benefit. I hope this gives you some idea. And with that, I would like to thank you. And these are the references. I think the slides will be made available in the part of the presentation. I would thank again Dr. Islam and Dr. Mohammed. Over to you.